why do countries differ in both the rates and the numbers of maternal and child deaths? And some of those answers are obvious and some of them are less so. So the obvious answer that people give is that countries differ greatly in their level of development and poverty, and therefore many countries will have, despite the size and their birth cohort, a much higher rate of mortality. And therefore, if you compare countries on the basis of rates, you will find that rates of child mortality may be very high in some countries which are small, just because for their birth cohort, their risk of dying is much greater. If you take the numbers, there are 5 countries which have almost half of all the global burden of child deaths. And that's related to their birth cohorts. So they have countries like India, which has such a large birth cohort, countries like Pakistan, China, Nigeria, which by virtue of their size and population may not necessarily have some of the highest rates of mortality, but have the highest numbers. So in our development of interventions and strategies for action at a global level, we need to take both things into account, where the rates are highest and also where the numbers are highest, because that's where the maximum gains can be made. So this differential or inequity between various parts or populations in countries is a relatively new development in our understanding of the social determinants of maternal and child health. They are generally measured by either economic or asset indicators like income or asset quintiles. Much less common is our understanding of those differentials on the basis of geography, on where people live, and not just a simplified measure of urban or rural poverty, but also populations that live within urban settlements, urban poor, the slum dwellers, which may have poverty and mortality rates higher than many rural populations. And also, of course, the importance of ethnicity, of tribal characteristics, nomadic populations. So it's very important now to disaggregate some of this data to understand these social determinants of health and survival, because therein lie some of the solutions. If you don't understand these differentials, both within countries and between populations, you are highly unlikely to be able to target interventions to reach those who are not being reached. Now, there are 2 levels of continuum of care. One is the care between pre-pregnancy, pregnancy, childbirth, newborn period, and later in childhood and adolescence. And that's the continuum that we recognize across the life course, if not the life cycle. And the other continuum is across health systems. So you have interventions that work through household level, community, and then you have outreach services that are generally linked to primary care services, and then in turn linked to secondary and tertiary care services. So that's a continuum across the health system. And for things to be efficient, both have to be very closely intertwined. So you need to be able to implement and layer interventions not only across the continuum of care and the life course, but also across the health system. Across the world, in the high burden target countries, the 75 countdown countries, which have between them 95% plus of all the global burden of maternal and child deaths. Now, if you look at that graph, it's a complex graph, but it puts forward some very clear observations. You see that the graph has people moving in and out of the health system. So for certain interventions, your coverage levels are around 30–40%. For some, they're virtually negligible. And for others, you tend to be doing better. So what are those 3 different types or clusters of interventions where we are doing differently? So the first thing to understand in this coverage graph is that we seem to be doing reasonably well globally with the kind of interventions that are delivered vertically through vertical programs and channels of delivery that are related to things like vaccine programs or vitamin A supplementation as part of these campaigns. And the reason why we're able to reach many people is that these are isolated programs which are very targeted and focused on achieving a certain level of coverage, but they have very little bearing with day-to-day care. for the kind of interventions that require functional health facilities, particularly facilities that are functioning 24/7, we tend to fall flat. So it's very important to recognize that coverage gap. And then the final coverage gap that you see in these interventions is for those innovations where the evidence is very strong of their impact and benefit, yet their global scale-up has been very poor. And I'm talking about things that need to be delivered in the postnatal period, like postnatal visits for newborns, or even things like zinc for the treatment of diarrhea, where the evidence has been around for almost 2 decades now, and the global recommendation has been around for well over a decade, and yet the global coverage rate of this intervention at a population level is less than 3%. And the major reason for some of that gap is because we have not, as a global community, been able to take good care of assuring a supply chain and making it absolutely certain that people in the right places where the need is greatest have access to these commodities. When you understand a lot of these dimensions in terms of why coverage rates are so low, you can also understand what needs to be done in terms of accelerating that coverage. So a big chunk of our work in the last several years has been not around just documenting what works, but how do you make it work? So what are the delivery strategies and channels that would allow us to implement these interventions at scale? For example, everybody knows that breastfeeding is absolutely critical for child health, nutrition, and survival. Yet it's not very clear how do you scale up breastfeeding through the promotion and implementation strategies to make this happen. So we now have a range of interventions and a range of delivery channels that allow us to perhaps make that change and be able to scale up these interventions. And in the limited time, I will only mention 2. One, the development of the knowledge that community health workers and some of these lay health workers can reach populations which are currently not being reached by skilled care providers or physicians or nurses. The second big innovation in recent years, particularly amongst the poorest of the poor, has been the provision of financial incentives and perhaps reducing the poverty barrier. To summarize, one of the greatest travesties of the current generation is these disparities in maternal child health and survival. But the hope is that we can deliver the kind of interventions based on our current knowledge, and if we are able to implement them at scale at the right level, that we could make a difference to these outcomes even within the same generation.